The patient is a 62-year-old male with a history of Klippel-Feil syndrome with congenital abnormality to the wrist. He underwent a proximal corpectomy approximately 10 years ago. These are his post-op radiographs. He presents now, approximately 10 years later, with advanced degenerative changes to the capitate and to the lunate facet. Patient is scheduled for total wrist arthroplasty. In this instance, approximately a 10 centimeter skin incision was made in the patient's previous dorsal incision. Sharp incision carried down to the level of the fascia where thick skin flaps are elevated. Close attention is made to protect both the dorsal and ulnar sensory branches. The interval between the second and fourth dorsal compartments are then elevated. The essential pollicis longus have been previously transposed. A radial-based flap will be made. Here we can see the fourth compartment, the fifth compartment tendons, and the second compartment. The wrist is flexed. There's bare bone grade 4 commilation change to the head of the capitate as well as to the lunate facet of the distal radius. Utilizing the carpal guide, a guide wire is placed down the central axis of the capitate. This is confirmed under fluoroscopy to be an ideal position. It is then reamed with a carpal twist drill and then tapped right to the level of the laser line. At that point, the taper post is inserted over the guide wire to the level of the laser line. The position of the screw is confirmed under the fluoroscopy, well centered in the capitate. Then utilizing the carpal reamer, the head of the capitate is reamed. It's important to start the reamer before it makes contact to the capitate. The carpal dorsal reamer is then placed to ream off the dorsum of the capitate. The capitate has now been prepared, and the carpal cutting jig is placed. Here, the distal aspect of the hamate and scaphoid will be excised. Note a minimum amount of bone has been removed. Next, with the radial drill guide, the carpus is measured. In this instance, a size medium distal radius component will be used. A guide wire is placed down the central axis of the radius, and then a cannulate drill is reamed. The radial V guide is placed, provisionally pinned, and the radial and ulnar core drills are used. They are then removed, and at the rongeur, the drill holes are connected together. The radial depth guide is then placed into the distal radius. And insert approximately 2 millimeters below the joint surface. A guide wire is placed, and then the radial surface reamer is used. This is used to give a very good anatomic fit to the distal radius component. Next, the trowel is placed. Again, note this was a size medium. As this was a revision case, I felt the wrist was still tight. So in this instance, we're going to ream further bone off the distal radius. To do that in this system, We're going to place the guide for the large component restabilize with a pin, and then use the rail and ulnar core drills to re-drill the distal radius. What this did was allow us to insert the rail inserter of the depth guide further more proximally, so further bone could be reamed. Fluoroscopic view show ideal position. Our trials are now being placed. And now I think we have a very satisfactory range of motion to the wrist with the trial components. The radial trial is being removed. And now the size medium rail component is being impacted in place. Fluoroscopic views show ideal position. Now we clean out our screw post. And the carpal plate is being inserted onto our central screw post. It's impacted into place with a Morse taper. And now with our drill guide, the index and hamate screws can be placed. Notice the congenital abnormality to the index metacarpal. We're still able to get a good screw placement into the index metacarpal. The index metacarpal is drilled. And our first screw is being placed. Notice it's not being tightened all the way, but snug. Our second guide wire is being placed for the screw. It's inserted right into the base of the hook of the hamate, confirmed on the fluoroscopy, and drilled. The second screw is placed, and then going both radial and ulnarly, the screws are tightened down. Fluoroscopy shows good position of the screws. The carpal articular component is then impacted into place, confirmed with the good Morse taper. And lastly, the poly component is being inserted onto our distal radius component. Fluoroscopic view show excellent reduction. And clinically, a very good range of motion to the wrist, both with flexion extension and radial and ulnar deviation. Only the ulnar aspect of the dorsal capsule is closed to help maintain as much wrist flexion as possible. And then the second and fourth dorsal compartments are closed, again leaving the extensor pollicis longus free. Post-op radiographs show excellent position of the prosthesis in both the AP and lateral planes. Thank you.